Welcome. People are arriving to the Beyond Celiac Town Hall. We'll give folks just a minute. As they're coming in, I'll go ahead and begin our introductions. Welcome to the Beyond Celiac Town Hall. I'm Claire Baker. I'm Senior Communications Director at Beyond Celiac and your host for today's gathering. We are recording this event so we can have it for later replay, both video and podcast, if all goes well. Before we begin, we just want to acknowledge what's going on globally. Like many around the world, we have the people of Ukraine in our hearts and our thoughts. And we're grateful for the organizations and companies and individuals who are reaching out to help in any way they can, big and small. For our community, the Association of European Celiac Societies is accepting financial contributions, and you can learn more about how to help by visiting aoecs.org. And there's a big banner on their site that says support for Ukraine. For today's town hall, I want to note that our sponsor is I'm Aware, longtime partner of Beyond Celiac and a groundbreaker in at-home testing for celiac disease. I'm Aware's goal is to empower people with better health, better health data to prevent disease, improve performance, and ultimately live longer and healthier lives. So it's good fit for partnership with Beyond Celiac for sure. I invite you to take advantage of an offer they have. Check them out at imaware.health and use the code BeyondCeliac10 all together at checkout for $10 off screening or monitoring tests. We're very grateful for imaware's support. Our special guest today is Stefano Guandalini, MD. Dr. Guandalini is an internationally recognized expert in celiac disease. He's Professor Emeritus of the University of Chicago and the founder of the Celiac Disease Center there. Dr. Guandalini's research efforts have greatly influenced the way celiac disease is diagnosed and treated today. In fact, his work contributed to the revision of 20-year-old guidelines for celiac disease diagnosis. Dr. Guandalini has been ranked among America's best doctors since 2008. In 2012, he received the prestigious title of Master of Pediatrics from the Italian Society of Pediatrics. And just this year, he published the revised Textbook of Pediatric Gastroenterology, Hepatology and Nutrition. Dr. Guandalini is also a medical advisor for I'm Aware. For today's discussion, we invited our audience to submit questions in advance. When you registered, you had a spot to type your questions in, and we've sorted and organized them by theme as best we could, and hopefully we will get to as many of those questions as possible. Our Beyond Celiac staff is monitoring chat, and as questions come in, we'll do our best. My team will do our best job to answer your questions right there in chat. And because we've got a lot of questions teed up, it might be that we're going to get to your question in due time. But because we have a lot, let's get this underway. Good morning, Dr. Guandalini.
Good morning, Claire. It's a pleasure to be here. Thank you for inviting me.
Certainly. I'm going to just jump in with questions, unless do you have any opening remarks? Do you want anything you want to contribute before we get going?
I just wanted to join you in saying that our thoughts and prayers are with the Ukrainian people in these terrible moments. So I think that is on our hearts and our minds constantly throughout the days, and hopefully this will end soon. But I'm ready to tackle questions on celiac disease and beyond.
Okay, very good.
No pun intended.
Well, there's a reason we picked that for our name. It works. So, all right. So first, the first set of questions are in the topic of risks of undiagnosed celiac disease. So first of all, let's talk about what it looks like when people are undiagnosed. Can they have celiac disease without any symptoms?
Yes, and that actually is something that we have come to learn by screening and diagnosing people that were first-degree relatives of patients with celiac disease. We knew that they had a higher risk of having, so we began testing them maybe 20 years ago or so. And so we have learned by this that we actually came to diagnose people that had absolutely no symptoms, or symptoms that were minimal enough not to require them to, seek medical advice. So absolutely, yes. And actually the current thinking is that perhaps even the majority of patients that have celiac disease have minimal or no symptoms. And that would explain why is it that across the world, even in areas where the awareness of celiac disease has been very high for years, the rate of diagnosis never exceeds 45% at the most of the people that are expected that we know have celiac disease, because again, most of the others, if not all of them, may have minimal or no symptoms. So that is true.
And talking about symptoms, traditionally the symptoms were thought to be GI related, but we're seeing more the neurological and psychological symptoms that may be signs of celiac disease, but are not on the radar screen really. How is that contributing to the misdiagnosis?
That's a good point too. Yes, with time, it seems that we are seeing more and more what we call extra-intestinal manifestations of celiac disease that can involve almost any organ, any system, from dental enamel defects to headaches, to liver issues such as elevated liver enzymes, arthritis, and then you mentioned neurological, psychological complications or presentations such as anxiety or depression, even hallucinations. So the spectrum is really wide. And clearly, one of the efforts that we are trying to do and that should be done is to increase the awareness of celiac disease by educating the medical community, not just the public, about the fact that you may have to look well beyond the gastrointestinal tract symptoms if you want to really be able to pick up all the patients with celiac disease. The manifestations are so protein that it really requires a high degree of clinical suspicion to check somebody for celiac disease.
Our community notes frequently that physician education is, if a lack thereof prolonged their diagnosis, and especially with something that's perhaps just not typical symptoms like neurological and psychological symptoms, that it can take a bit longer to get to the diagnosis.
Yeah, absolutely, and this is why at the University of Chicago we have been trying now for more than 20 years to push, on medical education and awareness by different means, by organizing what I call the celiac disease preceptorship days. So there were 3 days of full immersion on celiac disease that we were offering to doctors as well as nurses and dietitians across the US. They would come here, see patients with us and discuss on a very interactive way. We also, for years, have been doing the free screening for celiac disease because the reason was really that the awareness among the medical community was not that big. And as you were saying, if you present with the neurological symptoms or other symptoms, you may not get even on the radar of doctors for celiac disease. Fortunately, I want to say in all truth that the interval between symptoms onset and diagnosis of celiac disease that used to be 10 years on the average, there was a study showing that years ago, now seems to have much decreased, but we still have an average of 2 to 3 years of delay between symptoms and diagnosis as an average again. And one of the reasons is just this, that people think of celiac disease as the young child with, protuberant belly and foul-smelling stools and failure to thrive. But again, celiac disease is much more than that.
It's good to hear that it sounds like the length of time from symptom to diagnosis is shortening. That's definitely a sign of proof of improvement.
Things are definitely better. Yes, there's no question about that.
One thing that comes up, so, as a person with celiac disease, I looked back and realized I probably had been undiagnosed for a couple of decades based on symptoms. And so I got diagnosed and realized, that I was at a greater risk of some cancers. Can you talk a little bit about the cancer risk, especially for undiagnosed, and if you achieve any improvement after going gluten-free?
Sure. So it has been known for several years now that celiac patients have a high risk of developing some forms of cancer, mostly lymphomas and other cancers related to the gastrointestinal tract, such as a small bowel carcinoma. But the most common complications in terms of malignancies for celiac disease patients is the intestinal lymphoma, the so-called enteropathy-associated T-cell lymphoma, or EATL, E-A-T-L. It's not easy to define what is the actual risk because different studies have employed different methodologies. But I think there is an agreement that in general, the risk is about 50 to 100% more than the general population. Now, this seems a lot. But if you think at the actual numbers, it turns out that there are about 2 people out of 10,000 every year that develop lymphoma in the general population, okay? And then if you look at the celiac population, it's about 3. So it's way more than 2, but still we are talking out of 10,000 celiac patients, only 3 will develop lymphoma. And the good news is the gluten-free diet. There is no question that the gluten-free diet is very helpful in preventing most complications, including risk of cancer. In reality, there was a very interesting study. Well, 2 things I think I'd like to mention in this regard. One is that if you have a flat mucosa, what we call MARCH 3, that is the highest degree of intestinal damage that is seen in celiac disease, untreated celiac disease. If you have that, then your risk of developing lymphoma are higher. In addition, if you start a gluten-free diet and stick to it, and you have no cancer for about 5 years after the diagnosis, then your risks of developing cancer are down back to the general population. So that's a very, very good news, and really stresses once more the importance of adhering to a strict gluten-free diet, because that really is the way of preventing such terrible complications. But again, their prevalence, even though it's higher, is not that terribly higher. So no celiac patient should panic and to think about that. And yes, embrace the diet.
Right. So importance of diagnosis, and then importance of adhering to the gluten-free diet. And in my case, I have a lot more, because I'm diagnosed with celiac disease. My GI doctor is much more, he pays a lot of attention to me.
That's good.
And encourages me for all my regular checkups. Another risk for undiagnosed celiac disease is bone loss, osteoporosis, and osteopenia. What is the risk for people with undiagnosed celiac disease with regard to bone loss? And after you get diagnosed, should you do a bone density test?
There is indeed a higher risk of osteopenia all the way to osteoporosis in patients with celiac disease, untreated celiac disease. And in fact, it's calculated that up to 70 or 80% of adults with celiac disease at the time of diagnosis have a low bone mineral density. And this is particularly frequent in women, both young women and postmenopausal. The good news, on the other hand, is that while once on a gluten-free diet, within 2 years of gluten-free diet, about 80% of these reach a normal bone mineral density. So that's good news. Only about 20% of the patients with celiac disease that had low bone mineral density at the time of diagnosis, only 20% of them have still this problem 2 years into the diet. So the risk of fracture is higher for sure. In fact, I myself recall very clearly having seen a very young girl. I'm a pediatric gastroenterologist, so I think she came to my attention around the age of 5 with already 3 fractures in her history without being particularly active. So, and that's when she was diagnosed with the low bone mineral density. She had really osteoporosis already, which is unusual at this young age. But the good news is that she went back to completely normal bone mineral density within less than a year. And in fact, the children are known to be quick, you know, they have more plasticity, so they recuperate more quickly than normal mineral density. So once again, the importance of the diet is here. 2 years into the diet, only a small part of the patient that had low bone mineral density will still have that.
In an event we had a couple of years ago, one of our physician guests noted that if a man presents with osteoporosis or osteopenia, that should definitely be a trigger for celiac disease testing, because why else would that's just not a thing that happens to men as a normal course.
Absolutely, absolutely. There's no question about that. That is a big, big red flag, of course. Yeah. But I hope people get it, because sometimes they don't. I often quote the fact that a few years ago, I was reviewing abstracts submitted to the section of celiac disease of a major national meeting. And one of the abstracts was a survey inquiring on hematology, so the different field, not bone, but the blood. And the question asked to the hematologists was, if you see a patient with unexplained iron deficient anemia, would you check this person for celiac disease? 86% of the respondents say, no need. So that tells you what is the need of really hammering down the need to check for celiac in many, many conditions. But it's disturbing.
I'm going to change directions just a little bit. My next question is, where can we find the data on long-term complications for those with both controlled and uncontrolled celiac disease relative to the general population? What are our risks for things like diabetes and lymphoma, osteoporosis in the midst of, in terms of odds and percentages?
So in part, we said something on this. So the problem is that there are literally thousands of publications on celiac disease, and many hundreds dedicated to the different presentations and different complications if you stay on gluten. But it's hard to compare them because of different methodology, different times in which they were done, different populations that they were targeting, et cetera, et cetera. So there is no easy answer to where you can find reliable data. But there are, of course, reviews on celiac disease that tackle this problem. And again, as I said, the only thing that they seem to agree on is the higher risk of lymphoma and small bowel carcinoma. But with the kind of numbers I already said. Osteoporosis is very common, as we said, and we also mentioned that within 2 years of a gluten-free diet, most people with celiac will reach a normal mineral density. In terms of the autoimmune conditions like diabetes, so here is different. So we actually know these numbers. There was a study done years ago by a friend and colleague of mine in Italy on a large number of celiac patients, and they demonstrated really unequivocally that the later in life the diagnosis was made, the higher the prevalence of additional autoimmune diseases in celiac adults. In other words, if you have been diagnosed between 2 and 4 years of age, you had a prevalence of all autoimmune diseases, but mostly diabetes being the most common, and thyroid disease. You have a prevalence that was identical of that of the general population, so about 2.5%, 3%. And if you go at different age groups, like 5 to 7 years, 7 to 10, etc., then you see a constant, just a linear increase, which tells you that evidently celiac disease had been brewing there for longer, and the presence of gluten in the diet is what kept the inflammation alive and set the right inflammatory stage, so to speak, in order for additional autoimmune conditions to develop. So the sooner you are diagnosed, the better. Once again, we go to the same issue here. And the sooner you begin the gluten-free diet, better. But the higher risk of prevalence, the high risk after you have been diagnosed, if you have no autoimmune conditions at that point in time, and you stay on a gluten-free diet, then you can reasonably expect for the rest of your life to have no additional risk of autoimmune conditions. I'm saying additional risk, but you have to be careful because celiac disease is an autoimmune condition, and patients share similar genetic backgrounds to all other autoimmune conditions. So you are not preventing the onset of other autoimmune conditions. You're bringing your risk down to that of the general population, but there is no guarantee that you won't develop it.
So that's a compelling argument. We know from our community surveys and talking to folks in our community that people who are diagnosed, they try to talk to their family members about their increased risk and get tested. And we know that there are some family members who are just don't want to hear it. They don't want to get tested, partly because I feel fine. I don't have any symptoms, or they think, yeah, if I have celiac disease, that means I have to deal with this gluten-free diet, and I don't want to do that. So yeah. You can improve your long-term health outcomes by getting diagnosed and adopting the diet is one compelling argument for just get tested.
Let me add, unfortunately for my gender, it's usually men who have that attitude. They just refuse to be tested, and they feel invulnerable. I can't tell you how many times after diagnosing a child with celiac disease, we recommend the parents, and the mom gets tested immediately, and then they return to say, I just couldn't convince my husband. It's typical, the mentality of resisting this. But this is, if I may use this word, it's a stupid mentality, because you are actually not offering yourself the chance of having a healthy life. And it's stubborn. It boggles my mind, really. So the only way, as you were saying, the only way to try and convince them is by insisting on the fact that even without symptoms, they are at risk of complications. You may have MASH3 severe flat mucosa with celiac disease and have no symptoms. This has been proven beyond any doubt. There is no correlation between the intensity of the intestinal damage, that is the activity of celiac disease, the inflammation related to celiac disease in the intestine, and symptoms. You would expect a correlation. Well, there isn't. There is a correlation between intestinal damage and serology. So your TTG are gonna be higher if you have a higher degree of intestinal damage. That has been shown also convincingly. But strangely enough, there is no correlation with symptoms. So going back to your question, we should really do all our efforts in order to convince those who need to be tested, because they belong to groups at risk, and there are many groups at risk, not just first-degree relatives, that even without symptoms, they have to be checked.
The research we did a few years ago was that family members say they want to be informed about celiac disease, and they want it to be a one-on-one conversation, not a post on social media or a intervention at the family reunion or whatever. But and a lot we heard from many that they've tried and they feel like they're a broken record, not being heard. But keep after it. Keep your you're doing your best, and know that your efforts to try to help your family is for their benefit, even if they act mildly annoyed in the moment.
Yeah, no. So sometimes when I deal with stubborn resistance, I try to convince them. I say, you know what, it's your choice. I'm not saying you need to go on a gluten-free diet for life, if that sounds like a terrible thought. just get tested. You owe to yourself to get tested, and then it's your choice. We live in a free world, fortunately, so far. We live in a free world. So you get checked. You at least know whether you have celiac disease or you don't. And then it's your choice. You want to risk your health? You can do it, go ahead. But I would recommend that, but it's your choice. But at least get tested.
So speaking of testing, if I'm a person with celiac disease and I have kids, how I do what I'm supposed to, I get them tested, they come back negative. How often should I retest?
Well, one way of reducing the number of tests to be done in a child, in a family that has celiac disease, would be to do a genetic test first. Because if the genetic test is negative, that is, you don't carry any of these, we know there are specific haplotypes called HLA, DQ2 and DQ8. And the fact that a parent of a child has celiac disease doesn't mean necessarily that the children all must have the genes. Some may skip them, so to speak. So that's possible. But if that's not doable, or given the fact that the chances of having positive HLA are, of course, much higher in a family where there is a celiac case, then I would say you have to test them for the first time around the age of 3. There is no need, no indication to test before the age of 3, unless, of course, they have symptoms. That goes without saying. If you have a child that even at 4 or 5 months, if they have been eating gluten already, have symptoms consistent, then they have to be checked. Otherwise, you can wait until the age of 3. And if they are negative, then we recommend testing every 3 to 4 years. It doesn't have to be an obsession, but in the absence of symptoms, if everything is fine, the growth is fine, you have no red flag, then it's okay to do this every 3 to 4 years. And then there's going to be a point in which they will decide as young adults whether they want to continue to be checked or not. But again, overall, during the lifespan, the risk of a child that has a parent with celiac disease, the risk of developing celiac within the whole lifespan is just in the range of 15–20%. And it's slightly higher for females than for males because there is a high prevalence of celiac in females. So, that sounds high. But, when again, in talking to families, I always use the reverse. I say, well, that means you have 80–90% chances of never again, never in your life, rather, developing celiac disease. So, but because of that 20%, I think it makes sense to have this, in the back of your mind and get tested. Again, as I said, every 3–4 years. There's no need to do it more frequently in the absence of symptoms.
Okay. How does the presentation of undiagnosed celiac change, if at all, among children of various ages? Are there known or suspected trends that present correlated with male and female children? So are you, as a pediatrician, are you looking for different things at different ages? And what do you see different between girls and boys? So
I wouldn't say that there are differences in my experience from the literature. I don't think there are differences related to gender. Except, of course, you have delayed menarche, or delayed puberty that is evident by not having the first periods in female. But there is indeed a correlation of age with types of symptoms. So the younger children almost invariably have gastrointestinal manifestations. They may have vomiting alone, for instance, stunted growth, or more commonly, they have chronic diarrhea. They also have a change in personality. They become sad, introverted, not talkative, almost an autistic kind of behavior due to the harmful effect of gluten also on the psychological area. But mostly they tend to have gastrointestinal manifestations. As the child goes on and the manifestations of celiac disease accompany the age, they change. They tend to have more extra-intestinal manifestations. headaches, arthritis, sometimes in terms of GI, constipation, which is counterintuitive, but constipation is present actually in about 8% of the children. So the higher the age, the more common the extra-intestinal manifestations become. And I want to mention headache among the most common. And in children, one has to think always a short stature. Short stature, physicians, even pediatricians, tend to think when they have to deal with a child brought to their attention with a short stature, they think, of course, familial short stature, and that's a very good thought. And then they think growth hormone. But in reality, the prevalence of celiac disease as cause of short stature is way, way higher than growth hormone deficiency. So endocrinologists should really pay attention when assessing a child with short stature to celiac disease as responsible for it.
That's super interesting. Growth hormone is always what is suspected and not.
Yeah, exactly. It's called GH. It's in the mind of endocrinologist, GH. But now, thankfully, we pediatric GI working on celiac disease have been hammering with our colleagues a lot. So I retired from the U of C a few months ago, but until then I had many patients sent to me by endocrinologists who actually screen their children with thyroid disease or, of course, diabetes, but also with short stature. And as soon as they see it, even a doubtful value of the celiac serology, the child is sent to my attention, which is great, of course, because then we can really identify many patients who would have otherwise skipped the diagnosis.
Yeah. This is a question from a person who wrote in. She says, can you discuss the genetic component of celiac disease? My two daughters were diagnosed at ages 3 and 6. They're now 10 and 13. My son is 7. From genetic testing, we know he has the celiac gene. What is the likelihood he will develop celiac disease? And is he more protected since he's male? You've addressed that a bit. And will eating gluten raise his risk?
Well, I'll start with the last questions. Of course, if he is not eating gluten, he will never develop celiac disease. Celiac disease is a multifactorial disease, meaning it has a genetic component, but then it has to have environmental factors to be triggered. And the most known environmental factor is gluten. It's, of course, it's necessary to develop celiac disease. If you never eat gluten, you're not going to develop celiac disease. But that said, I do not recommend putting on gluten-free diet a child that has not been diagnosed with celiac disease. That would not be a good idea. The genetic. So let's talk for a moment about these HLA haplotypes. DQ2 and DQ8 have been identified as the genetic component of the possibility of developing celiac disease. Now, if you happen to have both DQ2 and DQ8, which is a possibility, then your chances of having celiac disease, your risk is very high. It's 1 in 7. If you have DQ2 in a homozygous state, your risk is about 1 in 10. And then DQ8 homozygous 1 in 12, and so forth. So there are several layers, but in general, let me make a simple statement here. In general, HLA, a negative HLA, means you will not have celiac disease for life. Are there exceptions to this? It's debatable. In my mind, no, because from what we know about the pathogenesis of this condition, you have to have either HLA DQ2 or DQ8 or both. If you have neither, then you can't have celiac disease. So the test is used mostly to rule out the possibility of celiac disease. Like, for instance, even in adults, they come to your attention and say, I think gluten is bad for me. I started gluten-free diet 4 months ago. I feel fine. I want to know from you, do I have celiac disease? And you want to do a gluten challenge? No way, I am too sick for that. Well, then I can't help. The only thing I can do is an HLA test, because if it is negative, I can tell you have no cilia. Now, it turns out in the US population, for instance, about 30%, so 1/3, have these HLA haplotypes that are consistent with celiac disease. So that's a lot. But given the prevalence of about 1%, it turns out if you make the arithmetics, only about 3% of those who have the genes will develop celiac disease. So that has to be very clear in answering your question, the question you put. In other words, only 3% of HLA positive, I said again, will develop celiac disease if eating gluten, of course. So the test is useful only to rule that out. Now, the question was on a child who had actually already, we know that there is an HLA consistent with celiac disease. So again, the risk, as I said, can be stratified depending on what is the situation, but in general, overall, you can say that it's about 1 in 10, so 10% risk throughout life. A little more for females, yes, a little less for males. That, yeah, the ratio being 1.5 to 1, females to males. So the recommendation is let them eat normally, and check them for celiac disease every 3 years, as we said before. Unless, once again, they develop symptoms, then that is the time to be checked with serology. We are fortunate that we have these blood tests that are so effective in screening for celiac disease. We didn't have them until about 15, 20 years ago. I'm old enough to remember all of this, the time when we had absolutely no serology, or a serology that was very poor, until the 80s, until the late 80s, early 90s, we had a serology that was really poor. It's only in the late 90s that we started having good blood tests for celiac disease. Now we have them, so we need to use them, but in a reasonable way.
So a little bit of a follow-up on that. So this woman has 2 daughters with celiac and a son that has the genes for celiac, and they're all growing up in the same household. We know that there's something that triggered it in the 2 daughters, since presuming they all live in the same house. Any research on siblings developing celiac disease? Because we do hear stories like that all the time of people who have, we know you have an 80% chance of not getting celiac disease if you have a parent with it, but what might be going on in those households where it seems like everybody who can get it does?
That's a very interesting question. Well, first of all, it's interesting that the 2 daughters have celiac and the son doesn't. So that already tells you the gender influence on that. Secondly, even though they live in the same environment, obviously, probably assumingly eating until the time of diagnosis, at least eating the same amount of gluten. And we can make that assumption too. So what is different besides the gender? What could be different is the way they were raised during the first 2 years of life, and the infections they did or did not contract during those very peculiar times. The first 2 years of life are crucial for the development of the immune system, not just the intestinal immune system. The intestinal immune system is like the director of an orchestra that directs really the development of the whole immune system. And the first 2 years of life are really crucial for that. You need to be exposed to certain antigen in order to build your memory and build your capacity to react. But if you are exposed to other sorts of solicitation, you may actually derail into unwanted directions. To make a long story short, studies have shown that viral infections in general, but especially respiratory infections, are detrimental if you have the genes for celiac disease in increasing your chances of developing. So that's one thing. The other thing is the diet. There have been a couple of studies, but very convincing studies, showing the importance of having, again, during the first and second year of life, for a child, having a diet that does not include large amounts of gluten. now we can debate what is large, what is not large, and we can go into the details of that. But suffice it to say that if you have a normal, usual amount of gluten like introduced in baby foods, and in addition to that, you have a diet which is similar to the Mediterranean diet. In other words, no refined sugars, no processed foods, no red meats, plenty of legumes, plenty of fruits, plenty of vegetables, olive oil, fish. That kind of a diet during the first year and a half, 2 years of life, that is highly protective. So even in the absence of, even having the similar genetic backgrounds, that kind of dietetic attitude during those crucial 18-24 months of life may seem to be making the difference. So I do not know the case of this lady and her daughters, but chances are they might have had a respiratory virus during the first year of life or two. They might have a slightly different way of being raised in terms of diet. So this is speculation, of course.
Yeah, thank you. Moving on to adults and celiac disease. For patients who feel like they're older, they don't feel like they're patients who are older and think that they won't benefit from being gluten-free. How do you change their minds? It's like, I'm old, I'm set in my ways, I've eaten like this forever. Why would I bother now?
Well, this reminds you of an anecdote, a true fact, that the oldest person ever known to be diagnosed with celiac disease was an elderly woman of 101. So a new diagnosis of celiac disease at 101. And I think she refused to go gluten-free, and I don't blame her, actually. But if you are, in the 70s or even the 80s, and you have a new diagnosis of celiac, by all means, please go gluten-free, because you're going to protect your health. You're actually even more frail. Your immune system is not as reactive as used to be, and so protecting yourself with the gluten-free diet is crucial. I think it just is irrational. An example could be that of the COVID vaccine. We have a safe and effective vaccine, and then some people refuse to be vaccinated for fear of risks which are not there. But I understand the risk and the fear, rather. I understand the fear, but it's irrational. It's an irrational choice. In terms of gluten-free diet, there is no risk of a gluten-free diet. There is no risk. So please embrace a gluten-free diet and don't be irrational. And one more thing. So many times I've heard from colleagues that deal more than I do with adult patients, that a patient that have been diagnosed with celiac disease being asymptomatic and initially resisted to going to the diagnosis, and then they finally decided to try the gluten-free diet, and then came back for follow-up after 6 months. They said, "Doctor, it's amazing. I thought I was feeling well. Now I know what it means to feel well, because I thought it was normal to have this, a little headache now and there, a little, bloating now and there. I thought I was well, but now I really feel a different person. I'm energetic. I wake up rested. I go through my day with energy and stuff like that." So even those who think they are doing well, they might not actually know what is the extent of the well-being that Mother Nature gives us.
You just told my story. I had no idea. I didn't feel well until after I got diagnosed and went gluten-free, and went, wow. I thought everybody just felt kind of logy and gassy.
I'm glad we have a live testimonial here. That helps a lot. Yes.
It's me. A couple of questions came in that were along the same lines. Like I didn't get diagnosed until I was 51, and I'm 61 now. Any long-term ramifications? And another one that was, I was just diagnosed and I turned 70 next month. What's the percentage of people my age with osteoporosis, dementia, immune disorders. And I know you can't really address individual issues, but is there research or information based on that influence outcomes depending on what decade of life you get diagnosed?
Yeah, well, for the autoimmune conditions, as I mentioned before, we have that important paper, which I think really settles the issue. So the risk is higher as you get older in being diagnosed. For other conditions, like dementia, I don't think there is an association with celiac disease. I don't think there is a risk. I will still start a gluten-free diet, of course, for the 100th time. But I do not think I do not think that the risk of dementia is higher. It is around 2% as it is in the general population. We talked about the osteoporosis at length before, so I think that should be that should have been clear enough. I can't point to a single source that has all the truth with all these numbers, because again, as we know more, also the numbers change. So, but I thought we gave already a good indication of what is the osteoporosis and fractures. The risk is pretty high, but even in the elderly, they should expect to have an improvement, if not a complete resolution of their low mineral density within a couple of years of the diet. And certainly the longer the diet, the more likely this to be. Then of course there could be, the endocrinologist could recommend additional measures to help with this. Vitamin D is questionable. I mean, it's useful to protect you and to stimulate your immune system. And don't get me wrong, but it seems for this particular indication in celiac disease, it doesn't seem to have a great role.
Okay.
But certainly a good amount of calcium goes without saying. Yeah.
This is an interesting one that we hear. Why am I gaining weight once I'm off gluten? I was not underweight to start with.
Yes, this is actually quite common. It happens because people tend sometimes to rely too much on foods that are manufactured to be gluten-free, and they in general they're not so healthy. Let me state that bluntly. Sometimes they are not fortified with vitamins or oligominerals such as iron. They have a higher content in sugars and in fat as well. I always quote the example of the English muffin, not that we eat English muffin all the time, but there are normal and gluten-free English muffin. Now the normal has about 120 calories and the gluten-free has 210. So it's almost twice as more caloric. And if you rely heavily on this, rather than products that are naturally gluten-free, all meats or poultry, fish, fruits, vegetables, I don't have to make the long list of naturally gluten-free products, or even products that are manufactured to be gluten-free, by all means, but try to rely on those that are more natural, that don't have that added sugars, etc. But it's quite common that this is one of the reasons. Now, the other reason, of course, is that you might have been malabsorbing for a long time. You were eating gluten, you had celiac disease, chances are your intestinal absorption was suboptimal. So some of the calories you were ingesting were actually dissipated in the stools and you didn't absorb them. Now that your intestine is healed, because the intestine heals really quickly in celiac patients on a gluten-free diet, then you are absorbing 100% of what you eat. So that's another reason.
All right. So we're going to give you some questions that have come in through chat. We'll just see how it goes. First one is, David asks, does the gluten-free diet mean 100% gluten-free, or is 90% gluten-free better than 0? Is it all or nothing?
It is all or nothing. A gluten-free diet is 100% gluten-free diet. A gluten-free diet that is 90% is not a gluten-free diet. And talking for celiac disease, it might be different from the so-called non-celiac gluten sensitivity. And if you want, we can open that Pandora vase. But remaining on celiac, We have been for decades and decades recommending zero tolerance. It has to be totally gluten-free. Now, that said, it is true also that there are different sensibilities. So there are sensitivities, how would I say, there are patients with celiac disease that can tolerate up to maybe 100 milligrams of gluten per day, 0.1 gram, which is still a minute amount, but some of them can tolerate that. And there are some that cannot tolerate even 20 milligrams. So, if you are lucky enough, you can talk, but 100 milligrams, what is 100 milligrams? It's 2 crumbs, maybe 1 crumb of bread, no more than that. So, from the practical purpose, by all means, gluten-free diet means you have to avoid completely. Now, cross-contamination is an issue. And I know it's easier said than done. I totally get it. I totally get it. It's much easier said than done. And cross-contamination is a risk always lurking there. Fortunately, I want to be optimistic here. There is a lot of research that is going on, and some of it is very advanced. So I do expect that within a reasonably short period of time, 2-3 years, we should have available on the market products that are safe and that would protect you from the risk of cross-contamination. And in some cases, even from eating that, bite of a slice, something, or bread, something like that. So this is going to be much better than the life of daily life of celiac patients, because the daily burden of the gluten-free diet is pretty high and has been studied and reported many times to be pretty high for celiac patients. So this is probably going to be improved a lot within the next few years. That's my optimistic but reasonable expectation.
We at Beyond Celiac share your optimism. We're working day in, day out to accelerate research for treatments toward a cure through funding research and through encouraging participation in clinical trials, because things are just moving along at a very rapid rate in celiac disease research, and it's exciting, and we're very hopeful.
Absolutely. So. Unfortunately, we lost the therapeutic vaccine that got all of us excited a few years ago. That was a very unfortunate story, but that's how science goes on and moves on. You have to experiment and try. You can't just make up things. So
right, and that we talk about shots on goal. Our little hockey analogy. The more shots you take, the more likely you are to score.
Right.
I've got another one from coming in from the chat. Can you continue to have symptoms even when your blood tests come back normal? So you've been diagnosed, you've gone gluten-free, your tests are normal, but you still have symptoms. What might be going on there?
There are at least 2 possibilities, probably more. One possibility is that you already had from the beginning an underlying and overlapping condition. IBS, irritable bowel syndrome, or even something more serious like Crohn's disease, or small bowel bacterial overgrowth. The list is long there, H. pylori. So you may have other reasons that explain those symptoms. So you treated celiac disease, you got rid of that problem, but you haven't gotten rid of the other problem, which was not diagnosed. So that's the most common. The other possibility is that you are actually still ingesting a little bit of gluten. Now, the celiac serology that we do and that patients really care about to have repeated every time they follow up with the doctor with tests that can be done at home, as you said before, but also the doctor's office that tell you whether or not your TTG is elevated. Those are very important. But sometimes if you eat incredibly small amounts of gluten, they might be enough to trigger inflammation and possibly also symptoms, but they might not be enough to trigger production of TTG that from the intestinal mucosa that spill into the blood that then are measurable. But in any case, we have done this study also in children and adults, and it might take up to 2 years for symptoms to completely regress in adults that follow the diet and has checked and confirmed by the serology.
We had one question that came in that was prompted by your comment about respiratory viruses. And so I wondered, the attendee wonders if there are any links between having COVID and COVID triggering celiac disease.
This is not known yet. It's hard to say because celiac disease is an autoimmune condition. It takes time to develop. It's not like an allergy. So, you know, we might be able to see this years from now. As I said before, in the example of the children that have a respiratory virus in the first or second year of life, they might develop celiac disease when they are 7 or 8 or 10. So it takes time for an autoimmune condition to develop, and the time that COVID has hit is very short. So I can't answer that. There are no studies answering that yet.
Okay.
Possibly, yes. Why not? Unfortunately.
Here's another question that came in through chat. As someone who has no GI symptoms at the time of diagnosis and without any GI symptoms on the gluten-free diet, what should this person talk to their GI doctor about? He or she doesn't know what to ask or talk about. You know, what do you show up and say, hey, I have no symptoms and nothing seems wrong, but I know I have this disease. I think this gets to how often do you need to follow up with your GI or celiac specialist if everything seems like it's going okay?
So if you have been diagnosed, so there are two things. If you suspect you have celiac disease, are eating gluten and have not been diagnosed, and your doctor say, nah, I don't think you have it, then I would highly recommend an at-home test, such as those that I'm aware does, because that way you have a very simple, low-hanging fruit, so to speak, kind of test. So then, if positive, go to the doctor, say, see, I did this test, it's positive, now where do I go from here? But if you have been diagnosed already with celiac disease and you are doing well, and you have no symptoms, and your serology remains normal, I think you have to still be seen by your doctor every, I want to say, 2-3 years, something like that. That is what everybody recommends. Follow-up is always recommended.
Okay, this question is, it ties into type 2 diabetes, and the question came from a person in India who's interested in, you know, the food available in part of the country is more white rice than brown rice. White rice consumption can increase risk of developing type 2 diabetes. What's some advice for managing the gluten-free diet in a way that's health promoting throughout, especially with an eye to type 2 diabetes? Is that a question that you're able to address?
Yeah, probably not. Type 2 diabetes, as you know well, is not an autoimmune condition. It's a completely different mechanism. So, and it has not been associated with celiac disease like type 1 diabetes, which is the juvenile form, which is an autoimmune condition. So I don't think there is a link between the two of them. And rice, whether brown or normal rice, is of course gluten-free, is not a cereal that contains any trace of gluten. So its use is safe in terms of not being associated or able to trigger celiac disease. It might be, but I do not have the expertise to answer whether or not this is linked to a higher risk of type 2 diabetes.
Okay, and we have just a minute left. I'm going to lob you one that's probably not a minute's worth of answer, but there's a question about refractory celiac disease. There's refractory celiac disease, non-responsive celiac disease. What are the differences and what are you seeing? What is your experience?
Oh, the difference are incredibly important. They're two completely separate things. So under the umbrella term of non-responsive celiac disease, NRCD, we group all the patients that fail, whose symptoms or serology fails to improve within 2 years of beginning a gluten-free diet. In children, people have tried to use a more restricted definition, like within 6 months. So after 6 months, if the child is not improved, you can already talk about non-responsive celiac disease. In adults, up to 1 to 2 years. If you continue to have symptoms, that's non-responsive. Now, studies have shown repeatedly, both in children and in adults, that by far the most common cause of non-responsive celiac disease is ongoing gluten ingestion. There is no question about that. Second most common cause, other conditions that were present before and that did not respond to the gluten-free diet. I mentioned Crohn's disease, small bowel bacterial overgrowth, but even constipation, irritable bowel syndrome, those are often responsible for non-responsive celiac disease. Refractory celiac disease is a minute fraction of the population of non-responsive, a minute fraction. And this term applies to those that have been correctly diagnosed with celiac disease, do not respond to the diet, continue to have symptoms because they are developing, the autoimmune reaction triggered by gluten is continuing to perpetuate itself in spite of the gluten-free diet. Usually it's elderly people, usually with severe malabsorptive presentations that have been going on usually for years before being diagnosed. Now, when that occurs, the gastroenterologist will have to investigate and tell you with some special laboratory techniques whether this is refractory celiac disease type 1 or type 2, because they differ profoundly. Type 1 is relatively manageable. Type 2 is more ominous. It has a high mortality rate, is much more difficult, and it leads to cancer in a very high proportion of cases. But again, we're talking about a minute fraction of the non-responsive celiac disease.
Well, thank you so much. This was definitely the gamut of questions for celiac disease and managing the gluten-free diet. We feel very fortunate that you are our guest here today. Want to thank I'm Aware, our sponsor again. Visit imaware.health, and if you get one of their products, add Beyond Celiac 10 in the checkout and you'll get $10 off, which is terrific. We're going to sign off now and wish everyone a good day and good health. Thank you.
Thank you. Thank you.